Hello, I'm Alison Rees. Myself and Tom Slater are going to present some research to you, which was a thematic analysis of child practice reviews in Wales. There's been a long history of learning from serious case reviews. A lot of that work has been done in England, particularly by Professor Marion Brandon, who's based at the University of East Anglia. This particular project was funded by the National Independent Safeguarding Board for Wales, and it built on a previous study that we've done, which has been reported in an article by Robinson et al. In 2018. And in the previous project, we looked at 10 domestic homicide reviews in Wales, 6 mental health homicide reviews, and 4 adult practice reviews. And we looked across all the different reviews for themes that spread right through them to look where the commonalities were. And we also took a multidisciplinary approach to this. So the current study that we're going to talk to you about today is the first learning from research into what are relatively new CPRs, child practice reviews. Child practice reviews replaced serious case reviews in 2013 in Wales, following recommendations from the Care and Social Services Inspectorate for Wales. And there was a sense that they needed to be slimmed down to be more fit for purpose because there were very huge, large tomb-type documents that were very difficult to navigate and learn from. Previously in England, they've retained the serious case reviews until late 2019, so they came to make those changes later. And in England, they're called Child Safeguarding Practice Reviews. Contemporary guidance can be found on the Welsh versions in Working Together to Safeguard People Volume 2 by the Welsh Government, and the link is here on this slide. The first review of the implementation of CPRs took place in 2015. This wasn't really looking at the themes of the issues that were coming out in the reviews, but more how they were being implemented. So it was just taken just over a year after they'd been first set up. And it was looking at practitioner involvement, the amount of time and resources, and how things were being disseminated. So this current study really is the first of the themes emanating from those reviews.
As Alison mentioned, the contemporary guidance provides further information about what a child practice review is and how it should be undertaken. A child practice reviews are undertaken by regional safeguarding boards where abuse or neglect of a child is known or suspected to have taken place, and the child has died, sustained potentially life-threatening injury, or sustained serious and permanent impairment of health or development. But there's also additional criteria, which means there's 2 different variants of review. And one of the things that came out of the previous discussions around serious case reviews was the fact that there's very much a blanket approach taken to all reviews. So in an effort to try and address this, they created 2 versions, the concise and the extended. For a concise review, that's a situation where the child was neither on the child protection register nor looked after a child on any date during 6 months preceding the date of the start of the review process, the start of the review. Extended review, that's where a child was on the child protection register and or was a looked after child, including a person who has turned 18 but was a looked after child on any date in the 6 months preceding the start date set for any review. So these 2 different variants, which means that you should see differences in the way that reports are actually produced and in terms of the detail involved. There are also differences around the forms of these. So they can also have historic and multiple abuse reviews. Historic reviews are something that's permitted under this situation. So things come to light after the event, many years potentially afterwards. There is the option now to go back and do a historic child practice review. There's also guidance about how reviews should be undertaken where instances of multiple abuse have occurred. So it provides extra clarity and guidance about the kind of things that we should be looked at and considered. And that very much fits with the contemporary agendas around the ACEs, so adverse childhood experiences, and tries to bring together how these different issues can intersect with each other. The criteria for historic and multiple abuse is the same as those previously identified, but obviously it widens the scope of potential opportunities to undertake reviews in the future.
So, what did we do in terms of gathering the data for this research? The research design was innovative and comparative, and we took a multidisciplinary approach. So, as I've already said, we were looking through the child practice reviews via a thematic documentary analysis, and we looked at 20 child practice reviews between 2000 that had been undertaken between 2014 and 2019. And we used 3 different disciplinary perspectives, and one from criminology, someone from law, and someone from social work. And each of the 3 people each looked through the child practice reviews and coded them from their own perspectives. And so we're really trying to ensure that we're getting away from any sense of just being stuck in your own discipline, what other people can see. And then we brought all those together at the range of different themes. After we'd done that, we then had a focus group with practitioners. We had 2 focus groups, one in North Wales and one in South Wales. And the practitioners were from management, some had strategic roles, some were in social services, police, health, and probation. And in those focus groups, we tested out the themes that had come through and to see if they resonated with the people on the ground, and indeed they did. And after that, we asked the people who'd attended the workshops to complete a survey with any more of their views when they've had a little bit more time to think about the themes that had emerged. So that was the range of data that we looked at on which to base these findings. So the findings provided us with 4 substantive themes. The first was hierarchy of knowledge, and I'm going to talk about each, or we're going to talk about each of these in turn. The second, which has often come through in terms of reviewing serious case reviews, was information sharing and recording and the difficulties with that. The third was partial assessment, and finally the fourth was the voice of the child. Additional elements also arose which we felt were really important to include, and those were some of the challenges involved in undertaking child practice reviews, but also thinking about how can we maximise the learning from them, how can we disseminate them, how can we actually make them much more useful to practitioners across Wales. So the first theme was hierarchy of knowledge. And there was a real strong sense from reading the reviews that professional opinions were prioritised above any information that was coming from community or from any family perspective. So even where there were worries and reports from others, professional opinions were often prioritised. Interestingly, within families, there was also a hierarchy of knowledge, with the priority being given to the adults over the children, so listening to the voices of the adults more than the children, and in fact we'll come on to look at the voice of the child later, but also listening more to mothers over fathers. And in fact, possibly unsurprisingly, fathers were often overlooked or not consulted in any interventions. The second part of the hierarchy of knowledge is the interprofessional and multi-agency. And there was some evidence from looking through the child practice reviews to suggest hierarchies between professionals and agencies, with medical staff perhaps being given more credence than other people working with families. Having said that, it was quite difficult to determine due to the language used in some of the CPRs, which just referred to professionals as a generic grouping rather than actually identifying which particular group of professionals they were referring to. And importantly, where there were professional disagreements and conflicts were existing, and you could see that through the child practice review process, really important that more effective use is made of conflict resolution processes. Carrying on with the hierarchy of knowledge, there was, and this really links to the prioritising of professionals as well, that there's a prioritisation of the types of evidence and medical information, even where it was inconclusive, was always prioritised over wider evidence from a range of other people. And this prioritisation led to a sense of a tunnel vision. And because of the hierarchy of knowledge, it can almost create this tunnel vision where you can't look beyond what everybody has already agreed has happened or is happening. And once those attitudes are formed, then they become really hard to challenge. And other professionals from different disciplines couldn't really challenge them. And Monroe identified this again in 2011. This can happen in groups as well as to individuals. And tunnel vision was also noted to come out as a theme from the previous review of the 3 death reviews that we undertook previously in 2018. And it really reinforced the themes coming from that previous study.
Information sharing is another substantive theme that came out of this. Information sharing and recording, I should say, sorry. One of the things that came out of this, and perhaps isn't surprising, is that there still seems to be some level of confusion around the sharing of information in non-child protection cases. That is to say, cases where there are concerns for the welfare of a child, and I use the term welfare there very specifically in relation to the Children Act, but there's a lot of anxiety about information being shared there where they haven't got permission from people holding parental responsibility, or even between agencies who might have worries but weren't quite sure what the legal basis for sharing it was. Now, Lord Laming in 2003 talked about this and was very explicit that actually we do have the ability to share information where it's appropriate and pertinent to do so, and we are doing so in accordance with our legal duties and functions. And I think one of the things that came out of this was a sort of recognition that further training was needed pretty much across the piece around sharing of information where we weren't already at child protection concerns, or where there were some concerns but where people weren't sure whether it met the child protection threshold or not. Similarly, there was concerns amongst practitioners about the complaints and reluctant to share information around that. So there was lots of anxiety about practitioners feeling that they couldn't share information due to the potential complaint that might result from that. Again, one of the things that we've wondered from this is there seems to be more need perhaps for supervision and training to more effectively identify and guide that process so that people are more readily capable of sharing information and aren't worrying about the implication for them as a practitioner, but are thinking about that child and that child's welfare. The introduction of the GDPR, General Data Protection Regulation, seems to have escalated some concerns and anxieties around this particular topic. From what we could see, again, as Alison mentioned earlier, there's a generic use of the term practitioner, which sometimes made it quite difficult to identify which agencies were acting in different ways. There did seem to be a sense that the GDPR implementation had led to some anxiety across the board, but particularly in areas of health, where the need for GDPR is very important, but this doesn't mean information still shouldn't be shared as and where it's appropriate to, particularly when it comes to safeguarding processes. And it is important to note that much like the Data Protection Act 1998 and much like the Data Protection Act 2018, if there's a good reason to share information, then you should be doing so if it's for safeguarding purposes. And that needs to be reinforced and clarified going forward. There's also issues about interagency information sharing, and that's hindered by a whole variety of different things. One of the things that came out of this was the lack of integration in computer systems and IT infrastructure. This seems to be a source of anxiety both within and across agencies. So a good example of this would be, it was noted that there's often multiple services, multiple systems being used in certain areas. For health, they might have ones that are being used by GP services, which might be different from the hospitals themselves. And then again, there might be differences between psychiatric services and physical health services that aren't necessarily all integrated. Similarly, pharmacological databases might not be linked up in the same way. And this causes issues about making sure that people within organisations understand it, but also then how you then share that information. Be able to share it in a way that doesn't risk or compromise someone's confidentiality can present barriers there. There were varied approaches to information sharing, so the threshold and manner and the way in which agencies would relate to each other could be quite different. And of course, remembering you might have overlapping health boards, police forces, and local authority social services departments. Being clear about actually what the process is for sharing information in different areas is something that can come out of that. There was also concerns about poor record keeping, inconsistent use of language, and a lack of chronologies. Now, the poor record keeping obviously is something that is a professional issue across the board, and everyone should be making sure their records are up to date. That was sometimes impacted upon by time constraints and wider working conditions, and that's something we'll come on to in a bit. The inconsistency around the use of language was noted to be important, and there were particular instances that were reported where terms were being used around particular forms of assessment, and people weren't understanding what that meant. That either meant that things were being missed and not happening, or some things were being duplicated, which just served to create different outcomes and more confusion. Lack of chronologies, again, be able to share a chronology across services and understanding which service has been involved at which time point is really important for getting an understanding of the situation of that young person and the family. And that wasn't always happening in a clear way. It's important to know that while there were lots of discussions around poor information sharing, there was also examples of good information sharing as well. There are clear policies out there that do work well. A final point on information sharing, when we're thinking about how we share information, it's important to make sure that just sharing information in and of itself is not the end of the process and doesn't necessarily resolve issues. If you pass across large volumes of information to a colleague in another service, who are unfamiliar with the format, the language, the shape of that information, it can actually serve to be detrimental rather than useful. Essentially, you can swamp someone with too much information, and that can lead to issues. So when we saw this, that we often noted that the police seem to be very proactive in the sharing of information. However, that would often mean that large volumes of information were given to appropriate agencies, predominantly social services, in a way that was completely unable for them to actually access and use it, i.e. there's just too much information, no distilling of pertinent or key information in a way that actually helps to inform their understanding. Equally, when we're looking at this, we noted that social services, predominantly children's services we're talking about here, had issues about sharing information with other agencies. It wasn't always clear that was being done in a timely manner, and there seemed to be some gaps in that information being shared. Between social services departments, you also end up with situations where information wasn't necessarily being passed between adult social services and children's social services, children's social care. And that meant that some opportunities for safeguarding were being missed. So there might be concerns for the welfare of a parent, that information wasn't necessarily trickling through to considering the welfare of the child. These were thankfully relatively rare, but they were occurring. And again, it shows potentially different thresholds, different ways in which information is shared, and different approaches to actually what we should be doing in those contexts.
Okay, so the next theme is partial assessment. And this is a sense that practitioners very rarely had the whole picture. In some part, that was because practitioners often focus on individuals without consideration of the wider families and the wider context of those families. So, for example, a parent might have a drug and alcohol problem, and people will be working with him or her, but they wouldn't be asking, are there children in the family? What's the impact on those children, and who is working with those children? So people was just seeing partial pictures rather than putting all the information together that a full range of professionals would know about a family. Similarly, new partners appeared without being discussed or followed up, and nobody was finding out where the new partner had come from, what that person's history was. So again, they had a partial picture of what was going on. One of the particularly interesting findings was the impact of being a large family. And in the study, there was one family that had 7 children, one family that had 6 children, 2 families that had 5, and a further one that was just described as a large sibling group, which one assumes is more than 4. And because there are a lot of difficulties in working with larger families, because there will be concerns about separating the children. So there would be more emphasis on trying to keep them together, which sometimes put more pressure on parents or extended family. There were considerations of the costs of where all the different children would go. And there were lots of practical considerations about whether there were foster carers, for example, for a large sibling group. And we also were aware of the difficulties when several children within a family all had appointments. And there were instances in the data where several children had appointments on the same day at the same time within the same family. And it was clearly going to be very difficult for the parents to get the children to those appointments. And children with special needs were seen as a significant stressor really in large families, because they're likely to be having more appointments, just to add to the general difficulties. And as I've already mentioned, grandparents and wider family members were drawn upon to provide support, which is appropriate, but sometimes there were really unrealistic and unfair expectations placed on grandparents and wider family members. So, for example, there were some grandparents who were already caring for two of their grandchildren, and then they were also made responsible for overseeing another four. Well, grandparents are not necessarily in a position to have the time and the resources to suddenly change their life to dedicate to oversee and survey 6 children, for example, and it was concerning that they were being expected to do that without anyone really thinking about whether it was possible, feasible, and the implications of that. Continuing with partial assessment, there was a theme coming from reading the child practice reviews about polarising representations, particularly of mothers, of seeing them as either good or bad. And there was a lack of understanding of the nuance of people's moods fluctuating, people's situations changing, and but they were just, it was a little bit like the tunnel vision, in that they were just polarized in one respect or the other. So mothers couldn't be seen to be middling. People tended to take a very polarized view of them. In terms of supervision, this also came through, and it was often quoted in the child practice reviews as an area that needed to be improved upon, with more supervision being provided. But there's a real risk that just stating that there's need to be more of a focus on supervision, or more supervision of social work staff, that it's just seen as a general panacea without really being very clear about what it's going to provide and how it's going to improve practice. Another factor within partial assessment was service disengagement. So we saw in quite a few of the cases families or parents being rolled off from services. So if they weren't attending appointments, if they were failing appointments, and as I've already said, in large families that was quite likely because they had competing appointments for the varying children. And then that wasn't being logged or passed on to other people. So cases were being closed without anyone else, other professionals, knowing that that had happened. So there was a real increase of vulnerability for those families. And the fact that they weren't attending appointments should have been a red flag, rather than people just not knowing and carrying on thinking that children and families are receiving support and are being surveyed by others. Partial assessment is quite a negative theme, but there were examples of very good practice that we saw, and we saw cases where practitioners were actually given space within their time and caseloads to manage complex cases, particularly in cases of child sexual exploitation. And we also saw where efforts being made to ensure that there was a consistency of worker, that there wasn't a changeover of staff, so that they could consistently work with children and families to avoid what is sometimes known as discontinuous representation. So to trying to avoid that churn and the impact of that for families.
One further aspect of that relationship with families that came out before we moved into Voice of a Child was talking about partial assessments in relation to practitioner disagreements. And one thing we did see through some of this work was that where practitioners were disagreeing, this wasn't necessarily always being done in an effective manner. So they might disagree, but then what actually happened from that wasn't always clear. And one of the things that came out of some of these CPRs was actually advocating the use of resolution procedures, partly to address the issues where you might have assessments that were partially incomplete, had different positions around understanding what was going on. And these conflict resolution tools, which do exist across agencies, are a really effective way of getting people to stop and think differently about what they're seeing. On to Voice of a Child. So Voice of a Child. One of the things that consistently came out across the CPRs was a lack of consideration about the child's daily lived experience. What is it like to live with the different issues and circumstances that they're facing? And there was a slightly sort of indication of a reductionist tone of identifying particular issues, but then not really considering how it would be to experience that. If you were that young person or that child, how would you feel about that? Equally, when you're thinking about that, needing to consider the life history of that young person, which might help us to understand a little bit more about the way that they reacted to different circumstances and decisions that were being made. There were instances of children being spoken to in front of parents. Now, it's occasionally included, rather worryingly, instances where the parent was potentially someone who was a cause for concern or risk to the welfare of that child, or where the parent might be placing undue pressure on a child to say particular things, which would then potentially impact upon our assessment of the situation and the circumstances. So the fact that this is still happening where it really isn't appropriate to do so is slightly concerning. As I mentioned earlier about large families, and again with large families, one of the things that comes out of this is it wasn't necessarily clear that the experience from different children's perspectives was being considered. So you have children of, let's say, a family of 7 children, there might be a tendency to focus on one child over the other, whether that be a child with additional needs, whether it be because that child's particularly young, whether because that child is engaged with youth offending services, whatever it happened to be. There was a tendency to lose sight of children in that process. So there is a need for practitioners to stop and think about the lived experience of that child for each child in that family. And obviously it's difficult sometimes because the circumstances might be equally impacting upon different children, true, but their developmental stage could be different, their previous experiences might be slightly different, and the way that they mediate or try and cope with the environment around them will also be different. And that really needs to be brought out through assessment and through understanding. One of the things that came out of the discussions with the practitioners was actually it's really important to think about the idea of what do we mean by voice of a child. And again, when we're looking at the child practice reviews, there was a slight tendency for this phrase to be used in the child practice reviews in a very broad manner. And what was suggested was that maybe we should reframe this conversation about children's lived experiences. And what we're trying to suggest here is that this is about moving away from talking about the voice of the child and actually thinking about what it's like for that child to live in that environment, which is a far clearer message, we think. I mean, also people can articulate it in their assessments in a way that makes it clearer to courts or to colleagues across different agencies about the impact that current circumstances are having on the welfare of that child.
Okay, so I mentioned earlier about some of the challenges that we saw that practitioners were facing, and also some points about the importance of the learning. So what we saw were the real challenges of very heavy workloads, particularly on social services, and the impact that that was having. And so quite often there was a sense that practitioners were only working with the most complex, most high-risk cases. Clearly, there's no panacea really for high workloads, and we also saw lots of changing of staff in some situations. I've already mentioned supervision, but supervision was regularly mentioned as a response to some of the difficulties that had happened within families and as an action plan. But it's really important that supervision is prioritised and to support practitioners to be working in these very difficult situations. Another challenge that we saw within the data was agile working and how difficult it is when workers have touchdown spaces, but they're not regularly meeting necessarily in teams. And the result of that is that there's no thinking time necessarily, or not enough thinking time and processing. And quite often, social workers come back to the office and have discussions and mull over situations, and agile working doesn't really allow for that in the same way. Another challenge, which Tom has already highlighted, are the IT difficulties. And the Rate Health, for example, have quite fragmented systems with a range of different software packages being used and a different set of databases. And that meant that not all the information was known to all the agencies or could easily be shared across all the agencies. And WICIS has been seen to be quite positive, but not everyone has access to it. So IT difficulties really remain to confound situations, and there still needs to be some work to overcome this. Tom has already referred to data protection and safeguarding, and it really felt that the result of the general data protection regulation has meant that professionals are much less confident about what information they can share and with whom, and they became much more cautious as a result of this. And given that data sharing has been known for many years to be an underlying cause of difficulties, particularly coming through via looking at serious case reviews, and then it's almost that the data protection system has confounded and made that much more difficult. And another challenge that we had as reviewers was that we couldn't determine necessarily the difference in some of the cases as to whether they were actually concise or extended reviews. What seemed to be happening is that if it was obvious that they were concise reviews, then it was seen as an opportunity for people new to the reviewing system to become involved and under the tutelage of more experienced reviewers. But it wasn't completely clear which were which and what the difference between them was. And I think that was quite a surprise for us because we weren't expecting that. In terms of maximising learning, there was a lack of context in some of the child practice reviews. So context had been deliberately stripped out when we've moved to the child practice review system, and that was in part for confidentiality reasons, but it's actually very difficult to make sense and to contextualise learning without having all the background details. So we felt that on balance there was a bit too much context had been stripped out of the reviews. Tom has already mentioned chronologies and timelines. They're not required as part of the child practice reviews, and in fact potentially could provide issues with confidentiality and anonymity. But certainly action plans should be stored with the child practice reviews, and several of them that were sent to us, we didn't have the action plans with them. It's really important that when they're stored, we can also see, and when you go and look at them, you can see what the actions were as a result of the review. Otherwise, it's difficult to take learning from that. interesting that there's a requirement for child practice reviews to be on safeguarding boards websites for 12 weeks, and that seems not not a great deal of opportunity for people to look at them. And that again, if we're going to maximise learning, they need to be available much more widely. And lastly, what we saw was a lack of involvement in some of the dissemination events. Workload of professionals might have impacted upon that, but actually there were not that many people attending dissemination events. And given that they are quite long and time-consuming processes and documents to provide, it's really important that we maximise learning by having everyone at the dissemination events, both management and practitioners, and we look at other ways to disseminate the material.
So, building on what Alison's just said, some of the recommendations for practice. We've already mentioned about the issues around GDPR, and one of the things that came out of the discussions with the focus groups particularly was actually saying that training around GDPR needs to be managed in more multi-agency settings, trying to move away from situations where training specifically provided in just one agency, and that will help to address some of the confusions around what different thresholds are across different areas. So there's a big drive about wanting some multi-agency training on this particular issue. In terms of information sharing, all agencies will have levels of information sharing, different systems, processes and structures in place to make that happen. And there's a big need to make sure it's happening in an effective format and timely manner. But the word effectively format there is particularly important. If there are policies and procedures there, do people know how to access them? Do they know how to use them? Are they actually fit for the purposes for which they're designed? I think, again, coming out of the focus group discussions was a recognition that most of the time this guidance is there. What is lacking is people's ability to actually understand, use and engage with it. Regional safeguarding boards may wish to consider reviewing supervision practices across agencies. Again, going back to the idea about if supervision is to be effective and to promote learning going forward, is there a need to actually work with other agencies to make that happen? How might that look, and how the function of it will need to be considered. But again, it's trying to move away from these siloed approaches that can actually just serve as barriers to effective working with each other. The supervision, as we mentioned already, again, this is something that needs to be looked at in interdisciplinary environments as well. So not just looking across agencies, but also across disciplines as well. As Alison mentioned a minute ago, actually being able to attend learning events is a really useful way of gaining a better understanding of where things could be going better and also what's working well at a situation point in time. Practitioners need to be given appropriate time to attend learning events. Now, obviously, agencies are across the board very, very busy at the moment, and that's something we fully recognise. But actually, the potential time that can be saved by having learning events that promote more effective ways of learning are far greater than having a few hours lost to a person attending these particular training events.
Okay, so recommendations for future child practice reviews. We're recommending that there will be a central registry for CPRs, and we are hopeful that this is coming. It's already been agreed in relation to the death reviews of the study that we were involved in previously. And this would mean that people would have access to them and could look at them at their leisure, really, and that they'd be available indefinitely rather than just for the 12-week period that they're currently stipulated. We recommended that action plans should always be stored and attached to the actual CPRs to add the context, but also to see how that learning was going to be actioned within this particular situation. We recommended that more contextual information needs to be added back into CPRs to aid learning. So whilst it had been stripped out to improve from the serious case reviews, that possibly had gone a little bit too far. We also thought that there's such wonderful potential learning tools that a range of creative methods could be utilised for dissemination. So they could be used within team meetings for discussion. There could be podcasts made. There could be teaching events, something like this around them. And that the whole, we need to really think quite creatively about how teams can work with them, how teams can learn across safeguarding borders from each other. And currently that really isn't happening. Reviewers, the people who are writing the child practice reviews, need to be given appropriate workloads so that they can undertake the CPR thoroughly. And training needs to be improved to aid the consistency of CPRs. We saw a really varied range of CPRs in terms of quality, and I think a more formalised and more detailed training programme could happen, which would improve that consistency. And a regular learning from reviews is needed. It's just not a one-off event that's happened and then put away and forgotten. That we constantly review learning, and in fact, as we have done, we've looked at themes across the piece, and what are the themes that are resonating from one to the other, so we can get a much more sort of aerial sense of what needs to change. And lastly, more clarity really being needed about concise and extended reviews. As I've already said, it wasn't always possible for us readers and researchers to determine really which were concise and which were extended. So I think that more clarity, we all felt that more clarity around this would be helpful.
So, I mean, we covered quite a lot of ground in a very short period, and what we're talked about today is very much a snapshot of a much wider piece of work. One of the things we would like to say is that, there's a lot of very good work being done by practitioners across agencies. Equally, the work being done by reviewers is, for the most part, very, very good. And we recognise there's a huge amount of work to do one of these reviews. Again, that goes back to that point Alison just made about making sure reviewers have time to actually do the work that they need to do to make these things as useful as possible. Unfortunately, some of the things that we're talking about aren't new. I think if we'd asked people before we even did this, I think things such as communication and information sharing would probably come up straight away. And we can look back at Marion Brandon's work and wider literature reports, and we can see that this is an issue that comes up time and time again. So I think the challenge that we're trying to raise now is about, well, how do we make sustainable changes going forward? And that's a very hard thing to do. It requires concerted effort and thinking across agencies, across practice, academia, policymakers. It's not easy. As you mentioned, there are some great examples of good practice going on. We were particularly struck with the way that there was real efforts being made to keep the same workers in place to work with young people and families as much as possible. Equally, there were some examples of where practitioners were stopping and challenging both their own ideas and colleagues' ideas about what was happening, and that really resulted in some useful reflections and ways of thinking about how we learn going forward. But alongside this need to make sustainable change, we also need to be thinking about how we make change at different levels, whether that be the individual practitioner, whether that be at the meso level, which would be more about looking at understanding local authority or health board guidance, and also things at the macro level, which might include regional, national guidance in various different guises. As we mentioned, the things about sustainability is making sure changes happen at multiple different levels. We've posed a few different questions here, which we thought might be useful. Our original plan was to do this as a series of workshops, and unfortunately, due to COVID-19, that hasn't happened. So this perhaps isn't quite as we would have hoped to do this. And things we were asking people to think about, so how do these findings resonate with your own experiences and observations? How might practitioners make better use of CPRs to inform future practice? And what would need to happen for you to be able to use them more fruitfully? And these are things that we'd be really interested to hear about. If you have ideas about these particular points, or you want to know more about the report and what we found, then please do feel free to contact either of us. We both pretty much live on our emails, so we are on there quite a lot. But if you do have particular questions, please don't be afraid to contact us and check anything out with us. Alison, is there anything else you'd like to add?
No, thank you for listening to us, and hope you found it interesting, and we'd love to hear from you if you've got any thoughts or ideas about how to improve the learning from child practice reviews in the future.
Well, thank you, and I hope this has been a useful process.